I want to welcome folks to the PCMH Learning Collaborative. Hope everyone had a really good spring break. We've got some really good stuff for you today, including our colleagues. Some incidental music. If folks can make sure that they don't put their phones on hold, that would be great. I think that's probably what's going on. Okay, great. Hey, Kristen, next slide, please. Just as a couple of reminders, please mute the phone when you're not speaking, but please do not put your phone on hold because of the incidental music that we'll frequently hear. Next slide, please. Okay. We're going to have a presentation from Arkansas Community Care's Dr. Steve Wegner. Dr. Wegner, are you on the line?
I am.
Okay, excellent. Glad to have you on. And then we're going to have Jolene Varner from Little Rock Pediatric Clinic talk a little bit about their experience in population management, and we'd like to have a good discussion about things that folks are doing. I'll give a little bit of an update as well towards the end on what the chapter is doing and some of the next steps that we are proposing for our chapter. Kristen, next slide, please. We have support from Arkansas Medicaid. We are appreciative of the support to be able to do this work. Next slide, please. Kristen, unless you've got a specific roll call, I'd like to just get on to let Dr. Wegner have the floor. All right. Okay. Dr. Wegner, it's all yours.
Thank you, Dr. Kuo. So this program has been something that's been evolving, and we want to kind of give you an update how it's evolved. First slide. So I think that you need to understand that most of the program was dictated and prescribed by Medicaid, and even the rates and who we contact and what kind of contract we can have and these sorts of things. But if I go up a little bit and talk about our more broad goals and visions, it's not necessary to provide a model that we are going to import from North Carolina, but a model that needs to work with you, the providers, and for the patients. And it's all around being physician-led and operated, and I know we've talked about that in the past, and I know that's what you believe in as well. Our contract says that we're going to provide care coordination and support for complex patients. These care coordinators are going to operate in the practices in the communities, but we need to bring the right people together, and I'll show you the slides of who we brought together. But basically, what we want to do is something that's going to work in Arkansas over a longer period of time. And I have to tell you, I'm very surprised and pleased that your governor and legislature saw fit to continue medical reform, I guess, because it's multi-payer, and that they are going to continue covering the exchange. We're not quite so lucky in North Carolina. It's here it's Obamacare, and there's a lot of people who don't have anything to do with any part of it. So we don't have anything like that here. So I'm jealous. Next slide. So Susan is going to speak in just a moment about something that she has found a concern about in terms of what we're doing and what other parties are doing. Susan Beasley. We also have Jennifer Gardner-Swift on the phone, and then Jackie Kincaid, and those are hires that I'll talk about how they're being trained and so forth in just a little bit. But Susan, are you on the line?
Yes, I am. I was on mute.
Great. Yeah, so you're also traveling, and I appreciate that. But you, this is something that you come face-to-face with, and I think it's just explaining how the different programs can work together. So you want to take that care coordination vital to practice transformation slide?
Sure. Thank you. So The most common question that I get asked is, which one are we, Qualis or AFNC? Are we doing the same thing? So we wanted to make sure that everyone understood that they are practice transformation, and their coaches are work to develop systems within your practices for workflows to better manage your population. And we work together with them. It's not a duplicate program, it's synergistic. So we have care coordinators using those workflows, and then we are working directly with those high complex, high-risk patients to improve the patient outcomes and performance. This is going to be a huge success because we're out there, boots on the ground, touching those patients in their homes, in the practices, and even in the hospital if necessary. So we're reaching out directly to the patients, not just, making phone calls, but actually going and doing the med recs in their homes and various things like that. So this is really important, and we work as a team with Medicaid, Qualis, AFNC, HT. All of the vendors are working together as one PCMH team to support you.
And I think that sets the next slide up is the advisory committee, and let me just talk some realities of what has happened. My boss is a family medicine doctor, and he had a lot of contact with the family medicine doctors in Arkansas. Leadership, he'd been on leadership groups with them in the past, and so he had some connection with the family medicine group and their organization, and they frankly they encouraged him to make this application, and are been participating fairly significantly. Most of these people are from the AAFP, but there's also representatives of the Medical Society, and that's basically the crossover with Chad Rogers, who's attending also. Those bells are not from England; they're from my phone that's going off. So I want to, on the next column, I'd show you some of the support people that you haven't been introduced to you. Denise Levis-Houston has been there several times. Ginger Wilder takes care of our program coordination and training, among other things. Angela Ford, who is with me now, keeps everything together here at CCNC. And then Gustavo Fernandez is going to speak about some very exciting approaches that I want to make sure we highlight in just a few minutes. So the next slides I'm going to go through pretty quickly because it's stuff that you have not only seen us present, but you've been working on your own. So nothing is new from here on. It's saying that there has to be some metrics before you can be eligible for shared savings. Our care coordinators are going to help the practices by developing and updating care plans, which has always been kind of a nuisance for everybody. Working on the high priority beneficiaries and make sure that they get appointments and get seen. We're working very significantly on transitional care, which is a problem, particularly with the adults. Everyone hates the inappropriate use of ED. We're also going to work on quality parameters such as well-child visits, appropriate asthma medications, ADHD patients and follow-ups. Oh, I'm sorry. I went way too fast, didn't I, Kristen?
Next slide.
So, next slide. Yep. So I covered the well-child, asthma, and the ADHD patients. Next slide. So the care coordination that's going on right now, those two people that I introduced earlier have been to North Carolina, they've been to some of our clinics, and then they've been trained here at our central office, and the things that we've been working on for almost 15 years. And the the strategies and how we implement those strategies to result in a benefit for the practices and the patients. That includes motivational interviewing, which we think is a very appropriate role for care coordinators. And in the practice, when they go into a practice, they'll work on the practice assessment and then together how they manage the high risk. Oh yeah, next slide. Yeah, I keep forgetting because I am going fast. So conduct the practice assessment, manage the high-risk patients, gaps in care, strategies how to overcome them, and then identifying the community resources, which we know is important. Now, that little noise that you hear there is not me. It's my phone is under control, so I apologize about that. Next slide. Assess the practice EMRs, medical records, what kind of documentation it has for a patient care plan, and then making certain that that is part of the program going forward, but all with the goal of supporting population management. And how do we what kind of strategies can we get to work with the practice on handling their high priority patients? So the next thing is something that you haven't heard about, and I think it's very helpful. You and us are worried about how they're going to do these shared savings calculations, and in some of the conversations we've had with Medicaid, they say, well, why do you care about that? And, well, we care like you care because that's how everyone's going to get paid. So we've come up with, we've asked Gustavo Fernandez, who has had a long history of working with the state Division of Health Statistics, but he's also been involved over the years with the CCNC program, and he spent some time looking at how we could do these calculations. Yeah, if we could ask that everyone mute their phones, I think that would help the others as well. So, Gustavo, you're teed up now.
Thank you, Steve. I'm glad to be here. What I have done for the past few weeks is to try to develop a tool that will be simple to use at the practice level and would allow the practices to estimate and project over the future their shared savings using different model techniques. Like, for example, it would be essentially a spreadsheet that would allow them, by entering each quarter 5 parameters from each quarter, to then dynamically estimate the savings that they would accrue if they were to maintain the level of spending of cost, if they were to reduce it, or if they were to increase it. And as you know, one of the issues that there is that the information is 6 months old. The last report that came in March has information only through September 30th of 2014. And in essence, there is no actual data for the performance year 2015 until September, because then the data will go through. Next slide. And there, what this tool is designed to do is to proactively make estimations based on current data. So these are estimations. They may or not be exact, but they are based on the best information that each of the practices has. Next slide, please. I am not going to present the tool right now. We are going to Arkansas in a couple of weeks, and we'll be doing that at the practice and the state level. But I just wanted to say that the tool in itself is an Excel tool, and it has embedded formulas that permit the more or less accurate projections of shared savings by each of the contracted practices and each of the pool practices that we are contracting with. So we are kind of excited about that. I think it's a value added and a win-win, because you can see there that the more we optimize the savings for the practices, we also win and the practices win. So as I said, that's that's basically where we are at. I'm still working on a final product, and we'll be presenting that in a couple of weeks. So that's essentially it.
So, Kristen, you can go to the last slide. And Dr. Kuo, would it be appropriate if we could ask for any questions now?
Absolutely. Absolutely. Go ahead.
Okay. Anybody have any questions? Okay, so hearing none, thank you all very much for allowing us to present. And as we roll these things out, we'd like to come back and give an update later on. So if you have any questions, Susan Beasley is the direct contact in Arkansas, but you're welcome to contact me or any of the staff here at CCNC. So thank you, Dr. Kuo and Kristen.
Okay, Dr. Wegner, thank you very much. Kristen, go ahead, next slide. Jolene, are you on?
I am.
Okay. We're asking folks to highlight some of the good work that they've done, and Jolene has graciously offered to discuss some of the work that she has been doing at Little Rock Pediatrics. So, Jolene, go ahead and take it away. We're looking forward to hearing what you're doing.
Well, it's not so much what I'm doing, but what a lot of people here are doing. I've just got a handful of slides, and there's a list of many things that I'm sure everyone on this call is doing the same thing. You know, I don't know. So I don't pretend to have all the answers or all the best ideas at all. But we do have 2 RN care coordinators that started working on this project, I guess late June, early July. And they're really the hands-on, day-to-day, kind of keep things rolling with our high-priority patients. They make contact with each patient by phone when those patients come in to see the doctor, whether it's a sick or a well visit. They, lay eyes on the patient. They assess, how they're doing with their condition at the present time. They talk to them about their treatment plan. How are they doing with their medicine? Do they need refills? And we spend with every single patient, regardless of, what their condition is. We talk to them about appropriate use of the emergency department. And we have used some of the brochures that are actually free from AFMC that we can either mail out or give to our patients that talks about should I be in the ER? That's the name of the brochure. And we also question our high-priority patients about barriers that they may be having. Like, I've been waiting on, a referral to whatever for 2 weeks, and we sort of intervene with that and try to get everybody on the same page about what the patient should be doing next in their treatment plan. So we've done some training with our staff, our scheduling staff, so that when the patient calls in for a sick visit, they also know how to check and see if they're also due for a well visit. And if we can't do it at that time of the sick visit, we at least get it on the books and get it scheduled. And once the patient's here, and even before they come in, our care coordinators have the ability, as well as the doctors, and just really any nurse, anybody that touches that patient's chart, has the ability to update the problem list, verify the medications, reconcile all of the current treatments as far as therapies, medications, any referrals that are outstanding that we maybe don't have an appointment for yet, or we're waiting on feedback from, and look at any outstanding reports or tasks that might be assigned to a physician, or some of our administrative staff might be working on, a renewal on equipment, that type of thing. We also have our schedulers working the monthly EPSDT reports that come from Medicaid that show which patients for each primary care doctor are due for a checkup. 9 times out of 10, they've either just had it or it's on the schedule, but we do catch them that way, and that's extremely helpful. Those lists, as I've noticed I'm the one that actually opens those letters, and I've noticed over the last several months that there's sometimes some doctors don't have anybody on their list, and there might be one or two. So I think we're catching our checkups really well because, like I said, those reports are dwindling. We try to schedule, like everybody else, we try to schedule the next appointment as they check out, and we have a system where they get reminder calls at least 48 hours prior to the visit. We're switching over to a new patient reminder system, and hopefully within 2 weeks that they will get either a text, email, or a call at the time the appointment is made, and then follow up at different intervals. And we will also be able to program it to notify them when their next checkup is due. So a month or two out from when it's due, they will start getting contacted by our system. Patient portal, we've had a patient portal for, I think, 3 years now. It's gone really well. People either use it a lot or they don't use it at all. But the ones that do use it love it. They have access to request appointments 24/7. They can request refills, they can request medical records, and they can actually get copies of their most recent chart notes. If the doctor can send it to the portal if they want the patient to have it. But they have reports for well visits as well as sick visits that they can get access to. We are using developmental screening tools at certain visits, and Dr. Rogers has established specific protocols for asthma and ADHD. This year, we've changed our approach to identifying our high-priority patients, and we're focusing primarily on asthma and ADHD, and so we've got pretty extensive protocols for that, and we're educating our staff and the care coordinators along those lines. Our care coordinators also review reports that we get daily for anybody that was seen in the emergency room or discharged from the hospital. They make phone contact with them. If they feel like they need to be seen, they go ahead and bring them in as soon as we can. And, of course, to meet the measures, we have same-day appointment available. We have pretty extensive same-day appointment with the BMPs, as y'all know. You know, you've got to have same-day availability. I think one of our biggest strengths, though, is our practice management software. That's, when we identified our high-priority patients for this year, we did not necessarily use all of the ones that Medicaid identified on AHIN. We have the ability to run a report out of our system that looks at diagnosis, how many times they've been in, medications they're on, and that generated what we felt were our true high-priority patients. And we sort of came up with a hybrid list of people from the AHIN site plus our own list, and we think we have a pretty good list this year of our high-priority patients based on that. Our system can also run a report and let us know who is behind on immunizations and it identifies patients not seen. And that can be filtered by payer source. It can be filtered by diagnosis. It can be filtered, as many ways as there are fields in our system. So that's been very helpful. And we've also, I guess about a year ago, implemented a mobile app for our doctors. And everyone who takes call has the mobile app on their phone where they can pull up actual chart note from the last visit, read all their notes. They can document in real time. They can look at the medications, look at their allergies, look at their medical history. And as we upgrade to the next version, they will be able to e-prescribe directly from their phone. Of course, all this
to a VPN line. They can look at home, but I don't know.
Sorry. Somebody had a question. The last slide that I wanted to share with y'all, this is not a HIPAA violation because this is my child, but this is an example of a clinical summary that we can give out to the patient as they're leaving the visit, and it has all the medication that they were prescribed. I'm having a hard time seeing that slide now, but it lists their allergies, it lists their demographics, what they were seen for, who they saw. If there were any immunizations given, it would have been listed there. And this can also be downloaded to a health information vault or the Blue Button, if y'all have heard of that. And they can also transmit this to another provider if they needed to. I don't know that anybody has actually done that yet, but that is an option with our clinical summaries. So I know that was pretty fast. Does anybody have any questions? We're just, you know, we're trying our best to keep patients engaged in their care, and for us, of course, it's parents engaged in their child's care, and it's always a struggle reaching them, having them come in on this at the right time, and so we're looking for strategies to address that in several different directions. Any questions?
Jolene, it's Dennis Quo. I think this is, I definitely want to open up to questions, but if you don't mind, I'd like to ask a couple, and I think this is fantastic work. One question is, how are you flagging high priority beneficiaries, particularly since, you know, I think there's certainly a role for for flagging patients that we know that we need to be following, you know, for good clinical care. And then, of course, there are patients who are being followed under Medicaid, you know, under the PCMH program. And ideally, those two groups should be the same. They're not always completely the same because of the way that the risk scoring, you know, may be a little inaccurate if we choose to use that, or another reason why those two groups may not be the same, of course, is that if you have a new patient who comes in midway through the year, and so that patient obviously would not be flagged as a high priority beneficiary under Medicaid. But I think one of the challenges that I think many of us face are, how do you know when a high priority beneficiary is scheduled to come into your own clinic, and how do you ensure that your care coordinator is able to catch up with that family and meet the family and do the assessment and the various care plan updates that you mentioned. How are you addressing that?
Okay, so the workflow for that is our system. I have created a flag, and each patient, we literally go through every single high priority patient and attach that flag to their EHR. So
okay.
Anytime anybody gets in that patient's file, they have a window that pops up, and it has a capital H, and it says high priority beneficiary. So we also created an appointment type. So if our scheduler gets a call and they open up that patient's file, they immediately know it's a high priority patient, and they make an appointment type of an HPB appointment. And so each morning, our care coordinators and our nurses look to see, they can just scan their schedule for that day, and the HPB will jump out at them. And our care coordinators will, I think they have a slip, I think they just switched over to using the slip that Dr. Rogers designed, that they take to the nurse. And so when that patient gets pulled back into a room and has the vital signs done, there's a little summary already there that says, you know, they need shots, they need, you know, whatever is currently going on that the nurse can remind the doctor about. And then after the doctor sees the patient, our care coordinators are contacted, and they go talk to the patient in the room before they're discharged from the clinic.
That's great. So at the beginning, of the process is that you are manually going through your high priority beneficiaries and tagging them or flagging them?
Yes.
Okay.
And that way we can run reports just on those patients if we want to. Now, all the ones that we have flagged as high priority in AHIN, those are the ones that we start with. But I mean, you know, we've had a few patients where the doctors have come back to our care coordinators and said, you know, I know they're not Medicaid, or I know we can't put them on the list yet, but they really need to be taken care of. So we go ahead and put an H on theirs, you know, a flag on theirs too.
Okay. And then the other question I had was, I was actually interested in hearing a little bit more about what you all were doing with identifying high priority beneficiaries, but this is actually a point of discussion that I wanted to hear what folks are doing. Since our high priority beneficiaries for 2015 were due today, I'm certain that all of us have at this point gone through and looked at our list and tried to do the revisions to our list. There's certainly, as you've mentioned, I know of numerous folks that have, you know, that have discussed some of the how the accuracy of the risk scoring that is provided to us in AHEN for our patient panels, because it's highly dependent on the number of claims that they have to work with, that sometimes the risk score may not accurately identify some of the patients that that we would feel needs to be a high priority beneficiary. So I'm interested in your hearing a little bit more about what you found by using your practice management software with regarding to what are the clinical, what is a description of a type of patient that you may have found that you use a combination of diagnosis, medications, and some of the other criteria with your practice management software. Basically interested in your experience in how to identify other high priority beneficiaries and what you found using your practice management software that may not have been picked up accurately in the risk scoring.
Well, we actually purchased a PCMH module that is part of the EHR that we have. But I ran a report out of that said, give me all your high priority patients, that had this pay source, or just, all your patients that have this pay source and between these ages. I mean, it just, several thousand came out. And we ended up just sorting out the ADHD and the asthma. But there were some that were, I looked at those that were still, considered high risk, had a high score out of our system, and they had multiple problems. And that, I think that's what was driving, like, what the different, how many problems were on the problem list, what their diagnoses were. I think that's what drove that. I'm not absolutely certain about how that piece of software works, but when I compared that list, like the top, I don't know, I think I did like maybe the top 15% or the top 10%, and then looked at the top 10% of what was on AHEN, I found it interesting that there was only about a 30% overlap.
Gotcha.
Like I was saying, we sort of, did a hybrid, but honestly, we primarily went with what we pulled out of our system. Because we don't always know why somebody was on the AHEN list as being high priority, because we may have seen them one time and they had a checkup and they were totally fine. We have no way to know. And so what we were finding over the last year, as you know, the doctors were like, why is this kid a high priority? Well, we don't know. I feel comfortable today. If a doctor came and asked me, why is this kid on the high priority list, I feel comfortable being able to tell them for each kid we've got on the list today.
And does this pull off your EMR, or does it pull off billing data, or is it a combination? Is it a combination of both?
It's pulling. I think it's pulling off both. I mean, it has number of visits on the report, and I'm happy to send you a copy of it. But it will say the number of visits, but it's mainly pulling directly from the chart.
Okay. Okay. I think that's an excellent example of something I'd encourage folks to do is to utilize your own data to try to isolate or, to try to identify high priority beneficiaries that may not have necessarily been picked up in, in the Medicaid, the Hopkins ACG scoring method, because one thing that we found when we worked at our own data with Children's was I looked specifically, it's actually something very similar to what you had mentioned. I looked at how many times children had been in as outpatients over the previous year, and that tended to predict a pretty good sampling of children with multiple conditions that really should be qualifying as high priority beneficiaries.
Right.
And regardless of which method you use, I think using your own data, particularly since it's more of a just-in-time data as opposed to lagged claims, may be a very effective way of trying to run a population report to identify a high-priority beneficiary. And I think you just illustrated an excellent way of doing that. I am interested also in if others on the call are able to share what they have done to identify high-priority beneficiaries this year. Since this is their second year, I figured that folks have looked at alternate ways, and now that we've had 2 different seasons to try to identify high-priority beneficiaries, I'm interested in seeing what other folks have done. Are other folks willing to can discuss what they did to identify high-priority beneficiaries this year? Did folks use a combination of methods? Did folks use did folks rely on the Medicaid scoring method? Did folks use chart reviews? Did folks use any other algorithms?
Yeah.
I'm curious. Go ahead.
Yeah, this is from Dr. Gersher's office in Harrison. And yeah, our is also second year we are doing it. For the first year, it was so quick, you know, I even didn't realize that we have to pick. So, you know, Medicaid automatically picked it, and we looked up in the AHN website, you know, who was our high risk. And my time was actually gone, so I really didn't have any choice rather than accepting whatever Medicaid told us. So I went through and I spoke with my qualis, you know, rep and all, and I figured out the way they pick up how much each patient costs, you know, based on their cost, you know, how much that patient is costing Medicaid. So if they cost a lot, they automatically become high-risk patient. You know, that's how I figured out, that's how the Medicaid picked it up. So I just went through all the patients and looked it up and then figured out, okay, yeah, they picked it up pretty good. You know, it just depends on ADHD. They are getting counseling. They are getting all the ADHD medication. That automatically becomes high risk because it costs a lot to Medicaid. And then if they, you know, so that's how they picked it up. So, and this year also, you know, it helped me, you know. It's very hard for me to, because I'm not the doctor, I'm the office manager. For me to go and pick up high-risk patients, because doctors do not have the time to do all this, you know. So I just like Medicaid pick it up, and then I go, you know, and I looked it up, and we see that we have a policy anyway in our office that any patient, they need any kind of referral or medication refill, you know, we see them at least 2 times a year, you know, if not 4 times a year. So that is our policy. As soon as they call for their refill or they need to, or anybody needs a referral, like any institution, we just look it up, and if we see that we have not seen this patient, so we just call them and say them, okay, we cannot do the refill or we cannot do the referral till we see the patient, or they went to the ER, you know, why they went to the ER, we just counsel them that they should not go to ER because it costs Medicaid a lot of money, and that's how they put it as a high risk, you know, according to me. That's how Medicaid looks at it. So that's what I'm doing, you know, that's what I will do, so this is us.
That's fantastic, and I think so you've used 2 other measures. You know, one is what has a child been costing, and then the other is you're looking at how frequently they've been accessing your system, sometimes in ways that may not necessarily come out through a claim. And I think that's the way to do it. Just out of curiosity, which cost data were you using? Were you looking at your own billing data, or did you get cost data from elsewhere?
The cost, you know, it is a PCMH report to AHN. If you go to the AHN login, and if you go, and they will have a report, you know, how much this high-risk patient cost you, and they have all these reports, the quarterly report, and they say, you know, which patient costing much, you know, they have all this. So I looked it up, and I thought that's what, and I talked to my rep, my PCMH rep. That's how they explained it to me, you know, and that's what I felt it, you know. It is the Medicaid website. It is through AHN, you know, whatever report they put it in there. That's how I look it up.
Okay,
so,
fantastic.
Yeah, and I think that is it. That's how Medicaid picks it up. Your high risk, how much a patient costs you, you know, what you are doing to lower that cost. Basically, that's what Medicaid is looking up, you know. According to my feeling,
their risk stratification method is actually based off of billing codes. It's off of the Hopkins Adjusted Clinical Groups method. So as far as I know, it's actually not directly based off of cost. And I think you know, there certainly is there certainly for a lot of patients there is a correlation between the risk scores and prior and costs, but it's only as good as, you know, the number of claims that they get. And you know, I've seen specific examples on our end where some of the kids who cost a lot were actually missed by the risk group scoring. So I think it's a good way to do it.
Yeah, sometimes diagnosis is also, you know, there are so many supporting documents, you know, not only cost, you know, also the diagnosis and what clinic, you know, what else they are getting, you know, like if they have asthma, you know, how asthma is controlled, you know. And so maybe their asthma is controlled with just 2 visits in the office, you know, with the medications that do not cost too much money for them. So, yeah, it is not always like that, but more, you know, there's quite a few like that, which is cost dependent. You know, some of the patients, they are not at all high risk for us, you know, but I looked it up, you know, they went to ER several times, you know, they're not compliant, they don't come to our office, you know, they just keep on going to different places, you know, they are getting the therapy which they are not supposed to get, you know, they are billing for it, so we are not aware of, you know, what they are getting in somewhere else, you know, so like the ER visits or something else which we are not following up with, you know. If they went to ER, are we following with them? If they go 4 times and they get admitted, and that is, here you go, there is a lot of, you know, they are not compliant with your office visit, they are not coming for their office visit, but they are going to ER, and finally they go to Children's Hospital. From there, here you go. But that is not a high-risk patient, it is just ignorance, you know, from the patient side. I see that sometimes like that too. So there are so many things in there, you know. So we really have to watch every patient, you know, we have to watch who is going to the ER, they are going for any valid reason or not, or they are just not coming to our clinic and supposed to do their medication refill or something like that, whatever doctor is sending them for, are they going to this specialist or not? You know, those kind of stuff, you know, we have to do, make sure they are doing it rather than just whenever they are sick, just end up in the Children's Hospital, you know what I mean? So these are the few things, you know, we have to look it up. And the Medicaid picks up pretty good. I just let them pick it, and then I work on it, you know. That is easier for me rather than me picking up because Dr. Ghosh really don't do much, and for me, you know, it's very hard. So I let Medicaid for us.
Those are really awesome points, and thank you very much for your for your thoughts on that. For folks, did anyone else have? I wanted to make sure that if folks had a chance to ask Jolene any questions that they had about the presentation, also. Okay, Jolene, thank you very much again for your presentation, for your thoughts and your experiences. And as I said earlier, we will be calling on other folks to discuss some of their own experiences as well. So thank you, Jolene, again, and for the excellent work and presentation that you gave us today.
Oh, you're welcome. Thanks for asking.
Okay, Kristen, next slide. Kristen, I don't know if you got the this is an older set of slides I had sent another set of slides earlier this morning. I apologize for discussing that here.
Oh, that's okay. I didn't receive slides from this morning, but I believe Amy was going to update us a bit about the ADHD, so that's why I put it on this slide.
Okay.
Amy, are you there?
Sure. Yeah, let me say a couple of quick things from slides that I had intended to mention. This will take about just a few seconds. Some general announcements of the PCMH. So the 2015 Q1 reports are on the AHIN portal now. If you haven't seen them, definitely go take a look at them. They also have specific changes in the we had talked in previous calls about changes in some of the metrics that they were going to have for this year. And in the most recent reports, you can definitely see the changes for this year. So all of the practice support metrics, for example, have changed. The thresholds for high priority beneficiaries who have a care plan has gone from 70 to 80%. HPB seen twice in the last 12 months has gone up to 75%. Inpatient stay who had a health provider encounter with intendees of discharge has gone from up to 40%, and non-emergent ED visits has gone down to 33%. So the other two things that really apply to us is under the shared savings metrics, asthma and ADHD have also changed. The asthma measure, the percentage of beneficiaries on appropriate asthma medications has gone from 70 to 85%. And for ADHD, the percentage of 6 to 12-year-olds who have followed within 30 days of prescription initiation has gone from 25 to 50%. So definitely take a look at those and see where you all are. I don't have any real updates from the state. There generally is a strategic advisory group for the state. There generally is a call every month, but the one that was in March fell last week during spring break and it got canceled, so I don't have any additional updates on there. There is an 18-month metric, which is to incorporate e-prescribing into your practice workflows. And then there's the 24-month metric is to certify that you're using your electronic health record for care coordination. Your EHR has to be certified by the Office of National Coordinator for Health Information Technology. If you have any questions about that, we found at Children's that our Medicaid colleagues were really good at being able to answer specific questions as to whether our software worked and was certified and was able to pass. So my suggestion is that you go ahead and make sure that all that is good with our Medicaid colleagues now. And that was really the main thing. If there are any questions, please let us know. If there are any questions right now, please feel to chime in. Otherwise, we can definitely turn it over. I wanted to let Amy talk a little bit about an ADHD learning collaborative that we're looking into for us as a group. Amy, you want to go ahead and take it away?
Yes, thank you, Dennis, and thank you all for taking time to be on the call today. We are looking at engaging with the National AAP Chapter Quality Improvement Network, again, to do something similar to the Learning Collaborative we did that focused on asthma, although this one would be focused on ADHD. The national office is still fine-tuning and honing what this Learning Collaborative would look like, but I wanted to go over what they know quickly and gauge the participants' interest on this call as to whether you guys think that this might be something that we might be interested in doing moving forward. So what they do know is that this ADHD Learning Collaborative is going to be focused on an evidence-based assessment and diagnosis. It's going to wrap around the care for for patients with ADHD, including and focused on their medications and subsequent behavioral treatments. So what they are going to do is use a portal that was developed by Cincinnati Children's Hospital called Me Health to collect data from parents and teachers by asking them to complete a Vanderbilt assessment tool that then the providers can use to diagnose and treat their patients. And this has been proven to decrease the turnaround time from getting that information from parents and teachers from about a month to less than a week. Another thing that they're wanting to do is to use interventions to ensure that the patients are coming in for follow-up visits after either initiating the patient on medication or changing meds. So they are going to figure out interventions that are achievable for the practices who are participating to do that, and then track the measurement of whether it's working. And then the third thing that they're wanting to do is develop and then disseminate a toolkit for the parents and families that have both national and local resources. So that's kind of the 10,000-foot view of what this learning collaborative is going to look like. They're hoping that it would be 25 points toward Part 4 of your maintenance of certification, and it will look like a lot like the asthma learning collaborative, where there are 2 in-person learning sessions and then 2 webinars. They're hoping that the first learning session would be in January of 2016. Data collection would start soon after that, maybe in January or February, and run through November of 2016. And they're thinking that they would ask practitioners who participate to enter 9 to 10 months of information to qualify to receive the MOC. And they're not sure how many patients per month they will be asking participants to track, but I'm sure that it will be manageable. So that's about all I know about the ADHD Learning Collaborative from the national office. If you guys have any questions, I can certainly try to answer them, or if we just want to open it up for discussion, or if we want to think about it and talk about it on our next month's webinar.
Yeah, folks, I want to give a couple of 2 cents about the potential for doing this with the national folks. One is that I think this fits really nicely in with one of the Medicaid PCMH metrics. And bear in mind, of course, that the private payers are adopting what seems to essentially be the same PCMH model for that Medicaid has already developed. I know from I assume that a number of you have already done your sign-ups for Arkansas Blue Cross Blue Shield's PCMH, and I actually have not seen myself the Blue Cross Blue Shield PCMH stuff pop up in AHEN yet, but my understanding is that that's exactly where it's going to be, and a lot of things that we do for Medicaid just crosses right over. Because ADHD is one of the metrics, I think that does match well. Number 2 is that I think it's important that we have something that keeps the momentum going along with additional education resources and data to really help us continue practice transformation and activities which extend our work not just within our own practices, but also within the medical neighborhood. Again, something that has been mentioned within the context of the Medicaid PCMH. And we think this will also slot nicely into year 3 of PCMH, and it's a really great way to be able to leverage our resources and do something really powerful with it, because certainly I think we'll all be in a really great place to make a lot of really good stuff happen. As you know, there's going to be a lot of, there's also a lot of renewed effort to try to have additional focus for primary care to be able to address mental health issues. And I think you'll see more and more of that coming out over the next year. So I think that all this will actually come at a really good time. So this is where we at the chapter are thinking of heading. I'm interested in your reactions, your questions, your observations as to whether this is something you might be interested in to try to get into towards the end of the year and into next year.
Can you hear me? This is Dr. Patton. Can you hear me, Dr. Quo?
Yes, sir.
I do have a question. You know, again, we're a small clinic with mostly Medicaid patients, and we've received the question from Qual Choice and Blue Cross about signing up for their programs that follow along with this, but I've been a little bit hesitant. A, we don't have that many insurance patients. B, we are spending so much time and work already on the Medicaid things without a full-time office manager that I was just hesitant to take on more work. For those of you that may have already done it, can you tell me, are you having to do anything extra because you signed up with Blue Cross or Qual Choice?
Yeah, so Dr. Patton, I can tell you that we're still trying to figure that out on the ACH side. You know, most of our primary care caseload is also Medicaid. What I have been told from our folks here is that the only so the documentation, you know, the attestations, all of that is. My understanding is that it all carries, whatever we attested for Arkansas Medicaid carries over to Arkansas Blue Cross Blue Shield. And so the only other thing that would need to happen is that we would have to designate high priority beneficiaries and do the attestation separately. I think from our standpoint that it is relatively minor compared to what we have for Medicaid. But I know that's not the case for necessarily the case for other practices. So I think that's a great question. I'm interested in see what other folks have experienced so far.
Okay, thanks.
Any other thoughts for Dr. Patton?
Yes, this is Sona again. I have something to say about that Blue Cross Blue Shield stuff because I don't know how I signed up with it, but I just don't know how it is going to work because Blue Cross Blue Shield do not have PCP. So, you know, though they come here to our clinic, but they are free to go any clinic, you know, they can go anywhere. So we are not really patient-centered medical home because we are not though we are called primary care, but they can go to any doctor anytime, which Medicaid patients really can't. So right. I don't know how it is going to work and where I'm going to find my patients there.
So what I was told for that group is that at some point fairly soon they are going to be doing a look back for the recent encounters, and a primary care physician would be assigned based on that. So. Yeah, so I think that obviously I haven't seen that yet, but that was my understanding. If anybody has other information about that, I'm interested.
And also because they don't need referral, you know what I mean? How I'm going to really catch them? Like if they go somewhere like for counseling, suppose they go to counseling, they're getting counseling at school, they're getting counseling at somewhere else. How I'm going to monitor them because school will never send us any paper, you know, because they don't need any referral. They're not asking anything from me. Only time we will come to know when patient comes and say, okay, I have a speech problem, school is getting there, you cleared it, you know, those kind of stuff. But in Medicaid, we get it, you know, from school, from different places, so we can, you know, they cannot get paid till we tell them yes or sign the referral form. So that way we can monitor a lot better than Blue Cross or QualChoice, which really do not need any referrals. So I don't know how that one is going to work. You know, that one will be a little difficult for me, you know, according to me. So I don't know how that one is going to work. So.
Yeah, no, I appreciate it. That's a good question. I think that's something we'll have to see how it goes as it unfolds.
Yeah.
Okay, folks, it's 1:15. Unless there are final questions, I want to respect folks' time and draw this to a close. I think we had a great discussion today, and as always, we're available for your questions or comments. We'll follow up, folks, about the potential ADHD project, and unless there are any other questions, y'all have a great day, and we will talk to you soon.